Hey everyone, my name is Bob Aran, I'm PGY3. This is my Grand Rounds presentation for Clostridium Difficile. So many of you probably know this as Clostridium Difficile. I had a name change about 3 years ago after some different genetic information had come out, putting it into different phyla. So now it's Clostridioides. As you guys know, this is one of the most common nosocomial infections. C. diff infects the human intestinal tract, usually after insult to the normal gut flora, like antibiotic use or hospitalizations. It's also the causative organism of antibiotic-associated diarrhea and pseudomembranous colitis. I'll go through epidemiology. I'll kind of talk about hospital-acquired versus community-acquired, and then we'll go through treatment options, case presentation, and medications we use for this. So for epidemiology, U.S. burden of CDI is about 500,000 infections annually, with up to about 30,000 deaths per year. And this is costing us about $5 billion a year. In the U.S., we've seen an increase of C. diff diarrhea, which has doubled from the mid-90s, from about 31 cases per 100,000 to about 61 cases per 100,000. That's a kind of important time frame because around the mid-90s, there was a new strain of C. diff, this NAPI-BI 027, more commonly known as 027 in the literature, which is a much more virulent strand, making much more toxin. This really started becoming a problem all across the world. A lot of hospitals reporting real high surges in C. diff infections from Canada to Europe to the United States. This really was tacked on to hospital administrators and healthcare providers' radars, and really was right up there with Foley catheter-associated infections and central line-associated infections. When we start talking about C. diff infections, one of the ways to classify this is healthcare associated or healthcare facility onset versus community acquired. The definitions for these are if you test positive in a healthcare facility after 3 days of staying there, so on day 4, it'll be classified as a healthcare facility onset. This will be considered, hospital acquired, in other words, so kind of a ding to the hospital system. Community acquired is defined as testing positive in a patient with no hospitalization during the 12 weeks prior. You can have healthcare associated if you fall between those two things, so discharge from a hospital and then testing positive after that, which actually doesn't ding any hospital, but is counted as a community-acquired infection. Kind of looking at these community-acquired cases, you can see that about 41% of C. diff cases are community-acquired. And it's a little misleading because, yes, they're community-acquired, but 94% of these community-acquired cases are people who've had healthcare exposure recently. So really all that's saying is they didn't spend the night in a hospital or sniff or step-down unit or anything like that. But most of them had been to a dialysis center, been to a doctor's appointment, had some sort of healthcare exposure. So this is a chart just kind of breaking down the demographics of a hospital-acquired versus community-acquired population. As you can see, the hospital-acquired tend to be a little bit older. Almost all of them have had antibiotics recently. PPI use is big. We'll kind of talk about that later, as well as malignancy. The at-risk population. So obviously anyone who's been in the hospital, been around healthcare workers, or been on antibiotics, we all kind of know that, but other people to kind of keep a close eye on them are the peripartum women, a lot of healthcare exposure there, people on PPIs, people with IBD, especially ulcerative colitis. They're at much higher risk of getting C. diff and higher risk of having a severe C. diff infection. Cancer patients, especially transplant patients, also higher risk. for CDI. And then the CKD patients and our ESRD patients, they also have a 2 to 3-fold increase in CDI occurrence and recurrence, as well as having a higher chance of having a severe infection. Another classification we use a lot when we talk about C. diff is a recurrent infection. So this is going to be defined as resolution of C. diff symptoms while on appropriate therapy or after completing appropriate therapy, with a reappearance of these symptoms within 8 weeks after completion of treatment. So this would be after the taper or after the initial oral vancomycin or however they were treated before, resolution, and then within 2 months getting the diarrhea back. Very common, 20 to 30% recurrence rate after first episode, and then again, high recurrence rate if you've had recurrence before. So the more times it's recurred, the higher chance it's gonna come back. People who are at risk for recurrence. Sorry about that. Again, females, older population, white population, obviously the antibiotics, the chronic kidney disease, and people living in nursing homes or have frequent health care associated contacts like dialysis, things like that. So we'll start a case presentation. This one's maybe a little bit more in depth, but hopefully it's a little more clinically useful for you in the real world. So this is a patient I saw on ID, 60 or 86-year-old male, past medical history of CHF, AFib, dementia, and a history of lymphoma. So he came in from a nursing home with recurrent loose stools. This patient was initially discharged from the hospital where he was diagnosed with C. diff after getting antibiotics for pneumonia. The reason he was in the hospital on the previous admission was for a hip surgery. He goes to the skilled nursing facility after completion of C. diff treatment, has to complete his antibiotics out there, starts having swallowing issues, he's a little demented, has some mentation issues, so they bring him back to the hospital. These are his labs. You can see no AKI, no white count. Lactic acid looked fine. He came in, he had a Foley catheter in, UA was positive for Citrobacter. CT was done showing infectious versus inflammatory changes, no evidence of toxic metacolon or colonic dilation. Vital signs were stable, and he had a pretty benign physical exam. So primary team started him on oral vancomycin, and they also started him on IV flagyl, 500 IV Q8, and they consulted infectious disease. The UA was positive for Citrobacter. This was sensitive to Recefin, so primary team had started that. Speech therapy came by to evaluate the patient. He was having some aspiration, so he was changed to thickened liquids. So we'll pause on this, kind of talk about a couple more things, and then come back to it at the end of the lecture. All right, so transmission of C. diff. So we know this is a fecal-oral route, how it's transmitted. It's important to know that some patients are going to be colonized. Some patients are going to have completed treatment and still have it. Some patients are going to be asymptomatic and colonized, and your chances of being colonized are much higher the older you are and where you are. So people who are in an acute care hospital obviously have a much higher chance of having colonization or chance of getting the infection, followed by people who are in long-term care facilities. People who are out in the community, not really taking antibiotics or low healthcare contacts, there's still a low but significant population there that are carriers. One of the biggest risk factors for, or one of the things that can modify your chances of being a carrier or getting an infection is actually being in a room with a patient who's had C. diff infection before. So someone has a C. diff infection, they get discharged, next patient comes in, room isn't cleaned properly. This counts for about 10% of CDI cases. And they've done the genetic testing to see that, yeah, the person who was in the room second has the same strain as the person who was there first. So this is a common thing and something that physicians and healthcare providers need to be aware of. You should also be aware that even after resolution of diarrhea, shedding of the spores can still last up to 4 weeks after treatment. So that's kind of on the long end, but just knowing that just because you're not having diarrhea, the patient can still be shedding spores. And on that effect can also still test positive, even though they're not having diarrhea. So in red, I have put in throughout the presentation IDSA guidelines. These guidelines came out 2.5, 3 years ago. And so I'll kind of sprinkle those in. I've left out some of the things like the pediatric recommendations. This is mostly a internal medicine lecture. But we all know C. diff spores are resistant to killing by alcohol. So we're told to wash our hands in patient rooms. It should just be pointed out, even though we all kind of probably know this, that the patient itself contaminated with C. diff, especially the patient's hands. So anything the patient's touching likely has spores on this too. So just keeping that in mind when you're, turning off, you're muting the TV or turning on the lights in the room, handing them a phone, all these sort of things likely have spores on them. So very important that you wear appropriate gowns and gloves, but also important that the patient gets showered frequently, things in the room get cleaned frequently, and that bedding gets changed often. So just important to know that that's something that the staff should be doing regularly. Kind of mentioned hand hygiene. So the official recommendation is actually you can use the alcohol foam if you've been wearing appropriate gloves and gowns and you are at low risk for touching things that have the C. diff spores. So the student that's kind of stands at the back of the room, they're wearing gloves and gown. If they take off their gloves and gown appropriately, foam it out, foam in, that's actually an okay thing to do. The best thing you could do is wash your hands with soap and water. But you definitely should be washing your hands with soap and water if your hospital's having issues with controlling C. diff, or if you've touched anything that the patient can touch, or obviously anything physically soiled. So if you're doing a physical exam on the patient, if you're moving their tray, those sort of things, then you really should be washing your hands with soap and water afterwards. So isolation. We need to continue this for up to 48 hours after a diarrhea has resolved. I mentioned before, people can still be shedding spores up to 4 weeks afterwards, but the official recommendations are 48 hours. It's a week recommendation. Honestly, the longer you can keep them on it, the better. And I probably wouldn't stop contact precautions until the patient's been cleaned, showered, room has been cleaned with bleach wipes, because if you stop, the room can still have spores and be contaminated, even if they're not having diarrhea anymore. So really, the more protection you can wear, the less you're going to spread it to other patients or move it around the hospital. This automated terminal disinfecting here at the bottom. So this is talking about like those UV lights that we use to clean rooms now, or some hospitals have sprays that they use. So none of these have actually been shown to reduce C. diff infections within the hospital. So really right now guidelines are good old-fashioned bleach wipes, normal cleaning that we've been doing, mechanical cleaning. That's the most appropriate way to clean a room after a C. diff patient. All right, antibiotics. So we all kind of know that antibiotics are really what's causing C. diff, but just to kind of go through who you should be concerned about. So your window of having a higher chance of C. diff after antibiotics can be up to 3 months. So patient who had antibiotics 2 months ago, C. diff should still be on your differential on that person. They're at highest risk while they're taking the antibiotics and within that first month after antibiotic exposure, but they're still at higher risk for 3 months after completion of therapy. And then obviously the longer they're on antibiotics, the higher risk they are as well. And so obviously the recommendation, discontinue antibiotics when not necessarily, use the lowest dose and length of time as possible. And then start treatment for C. diff when you have clinical suspicion of C. diff. So if someone's on antibiotics, they start having diarrhea, it's recommended that you actually start treating them for C. diff and get the stool culture, treat them while you're waiting for the results to come back if your clinical suspicion is high enough. So mentioned acid suppression as a risk factor earlier. So this is kind of a controversial topic in the literature. There really isn't hard evidence showing that PPIs or H2 blockers increase the risk of CDI or increase the risk of recurrence, but it correlates so well that people seem to think that it is a contributing factor. The issues with this are really, it's hard to tease out the biases. When you see someone on PPI, is that person getting tested for C. diff more often because they already have underlying bowel disease? That's why they're on PPI. Is the PPI itself causing diarrhea? Or is it that the PPI is destroying some of the gut biome in itself, which is increasing the risk of CDI? All these questions are kind of hard to parse out in the literature. I like to look at the meta-analysis just because each one, there's so many studies looking at this stuff. And the big meta-analysis, most amount of patients, most studies, they're looking at these things and they're really, they can't find strong statistical evidence that PPIs increase the risk for initial CDI or for recurrent CDI, even though the data seems to trend like it does. In regards to recurrent CDI, the big studies that they've done, these are, maybe not cardiology numbers, but, 1,600 patients. The last study was, over 300,000 patients. Still can't find a statistical significance showing that PPIs cause CDI or make it worse. And then there's been no randomized controls trials showing that PPIs cause CDI or make it worse either. So the official recommendations from the IDSA guidelines are actually, cut down PPI when you can. Don't use it if it's not necessary. Use something else, Tums or something like that if you can. But there's no actual recommendation to stop PPI because of C. diff or to prevent C. diff. All right, so diagnosing C. diff infections. So you're looking at a patient with unexplained, new onset, over 3 times a day, unformed stools within 24 hours. That's your classic patient. The trick there is unexplained. A lot of times you can use other factors to explain why someone's having diarrhea. For instance, they have a history of IBD. Maybe they've been started on tube feeds. Maybe that's why they're having more than 3 unformed stools. The issue with that, where you don't want to get tripped up, is those things a lot of times actually increase your risk of C. diff anyway. So if you have IBD, maybe it is an IBD flare, but maybe it is C. diff because they're at higher risk of getting C. diff. So really, when you start thinking about C. diff, you should probably be testing people for it, almost like HIV. If you kind of think about it, maybe you should be testing for it because a lot of the risk factors can cause C. diff as well. And then once you diagnose C. diff, we kind of break it up into 3 different areas. So you have non-severe C. diff infection, you have a severe C. diff infection. The differentiation between that is a white blood cell count at or below 15,000, and then a creatinine at or below 1.5, with severe being above both those 2 thresholds. And then a fulminant C. diff infection is hypotension or shock going along with your C. diff infection. Also, toxic megacolon or ileus seen on CT scan. IDSA actually makes a recommendation for a multi-step testing algorithm. So this is kind of getting in the weeds, but just so everyone's kind of aware that when you're testing for C. diff, it actually should be a two-part test. And the reason they want to do this is kind of highlighting this chart here. Sensitivities for a lot of these tests are pretty high, really good, but the specificity is pretty low. A lot of that comes with that not all C. diff bacteria form toxins. So just because you have a Clostridium species in your stool doesn't actually mean that it's causing C. diff infection, because you're not getting the toxin. So they like to use two different tests to look at this. Some of the tests you may see out there, cell cytotoxicity, neutralization assays. You can have your immunoassays. The glutamate dehydrogenase assay, immunoassay is a very common one. And this just looks at common antigens seen in all C. difficile species, not necessarily infectious ones. And then the NAAT, the nucleic amplification assay test, is also another common one to be paired with. The toxigenic culture is actually culturing out the C. diff species in the lab on the petri dish, and then testing for toxins. This is actually super laborious. It's kind of used as the gold standard, but it's not standardized. It takes a long time, so not very many hospitals actually do this. But it is kind of where the C. diff smell term comes from when you actually grow it on the petri dish. And then speaking of C. diff smell, I just want to touch on this. So everyone listening to this has probably had a nurse tell them that this patient has a C. diffy diarrhea, or their diarrhea smells like C. diff. People have actually looked to see how reliable this is. I found 3 studies that seemed reasonable. The 2 earlier ones were actually just case reports. So the nurse would say, hey, I think this person has C. diff. They would test them. 84% of those people in the first test, and 55% sensitivity in the second study, kind of show that some of these nurses actually maybe had a better than 50-50 shot, but they also had clinical understanding what the patient was going through. There was one blinded trial with 18 nurses, varying range of experience, and that was no better than a coin flip. So really, when you can kind of, when you hear a nurse say this person smells like C. diff, how reliable is that? Maybe not so much. You should really just go off of the case presentation. Are they having new loose stools, more than 3 a day? Is this acute? And do they have risk factors? Like, have they been on antibiotics? Have they been in the hospital? Things like that. All right, so who are we treating? So you're going to actually treat the patients, obviously, that show the signs and symptoms. Over 3 loose stools a day, positive diagnostic laboratory test. Really, the 2 important things, just to make sure I've said them. You do not need to treat patients who test positive and are not having symptoms. So I mentioned this a couple times. You can have a positive test and not have an infection. So maybe you completed it, a course of antibiotics, and you're no longer infected, or maybe you're colonized. But people who have a positive C. diff test and no diarrhea do not need to be treated. And then people who you have a high clinical suspicion that they have a C. diff infection, you should start treating before you get the test back. The test will probably come back positive anyway, like we just kind of mentioned. So if you're really concerned for an infection, especially if they're fulminant or going into shock or something like that, you should definitely start treating before your test results come back. All right, so treatment options for initial non-severe and then initial severe. Very similar. Really, the only difference is for a severe infection, there's no role for oral flagyl. In an initial non-severe, you have an option between vancomycin, fidaxomicin, and if you don't have those 2, as a weak recommendation, you can use oral flagyl. Although I can't see a situation where you don't have oral vancomycin or fidaxomicin. So really, those are the 2 go-tos. If you have severe infection, so over a white count over 15,000 or a creatinine over 1.5, go for the oral vancomycin and leave out the flagyl. If you have fulminant disease, this is where IV flagyl comes in. So a lot of this is just to get extra hands on deck to fight infection, but this is also in case you have an ileus or poor absorption or motility to the gut if you're doing oral vancomycin. Here you're giving oral vancomycin 4 times a day with the IV flagyl. There is recommendation to give rectal enemas of vancomycin if patient's NPO or has some sort of ileus. And just know that this is 500 milligrams and 100 milliliters of normal saline per rectum every 6 hours as a retention enema, meaning that it's supposed to be clamped and held there for some amount of time. Anyone who's tried to do some sort of enema like this know that logistically this is very difficult to do. So if given the option, you should definitely go for the oral vancomycin and then add on the IV flagyl, however you're administering the vancomycin. We should all know kind of the surgical goals for toxic megacolon in the setting of C. diff, and their goals are going to be subtotal colectomy with preservation of the rectum. And then if they do a diverting loop ileostomy, you can do colonic lavage followed by integrated vancomycin flushes from your point of view. All right, and then treatment for recurrent disease. So if for any reason someone got oral flagyl for their first dose, then you kind of can use anything other than oral flagyl. If they got vancomycin for the first dose, you can use vancomycin again, but you have to do a tapered or a pulse taper after retreatment. You can do vancomycin followed by rifaximin, or you can do fidaxomicin. And you can do fidaxomicin whether you did vancomycin, fidaxomicin, or flagyl as your initial treatment. On the recommendation list is also fecal microbiota transplantation, which is not something we do here. I'll kind of touch in a little bit on that. And not mentioned in the guidelines is a medicine called Simplava. I'll go over that here in a minute, but that's another option that we can use now. All right, so fecal microbiota transplantation. So this is something that a lot of the big centers are actually doing. It's a very common thing to do right now. We're not doing it mainly because no one in Tulsa is doing it. But if you go somewhere and it's a thing, I'm going to go through it so we kind of have some idea of what it looks like and what it's all about. So this is obviously taking stool from a healthy donor, giving it to a patient who has an unhealthy or damaged gut microbiome. We're talking about this in the setting of Clostridium difficile, but it can also be used for IBD. A lot of the reasons we don't have it are the barriers to getting a program like this started. So one, you got to have someone who feels comfortable doing this. So it's usually given through the endoscope. So either an EGD, but most commonly, most effectively through a colonoscopy. You got to have the stool samples or the donor stool. You have to be able to store this. It is a transplant technically, so you have all the hospital regulations associated with that. There's some safety issues. It's got to be screened properly so that you're not infecting anyone else. And then you got to make sure that you're not causing more harm, because there have been some case reports where FMT have flared IBD. And it was being treated for recurrent C. diff infection. It actually wasn't C. diff infection. It was an IBD flare and things got worse. So you have that risk factor there. As far as transmitting diseases, from really what I saw, the most common things that get transmitted are actually like GI viruses, so like norovirus. Everything else is pretty well screened out. Patients who apply for donor get tested within 2 months of donating their stool. So big diseases are really not that common. Success rate for FMT very high, over 90%. And we'll kind of break that down a little bit, but it's almost 100% if you have a failure and then a repeat. Their guidelines, the European guidelines, almost recommend this as a first, can recommend this as a first recurrent episode, or if they're at high risk for recurrence. So they're a little more aggressive with FMT than we are here. Again, kind of talking about the donors, really you have two different ways to donate. You can either have a donation from a single person. That person is usually chosen by the patient. So it's usually like a family friend or a loved one or something like that. You get the sample from them. Or you have a universal donor, which is essentially several stools from several people that are put together by a company. That company processes it, freezes it, and then delivers it to the hospital who requests it. That is by far and away the most common one. It's just the ease of having another company collect the samples, freeze the samples, package the samples for transplantation is much easier. So if you ever see this happen, what they're pretty much going to do is make sure that this is a C. diff infection. So you're going to see oral vancomycin given for 3 to 4 days prior to the FMT. This is to make sure that their diarrhea improves, kind of confirming that this is actually a C. diff infection and not like a flare of something else or another cause of diarrhea. They hold the antibiotics, and then they infuse the transplant stool. Like I mentioned, very good success rates. You see that number 84 to 93%. That is actually based off location for a colonoscopy. So if you can make it all the way to the right side of the colon, that's over a 90% success rate. Sometimes because of inflammation or other things going on, you can only make it on the left side of the colon or spike flexure or so, and that has a little lower success rate, 84%, which is still pretty good considering recurrent infections can be up to 30% or higher, and then subsequent recurrent infections can be up to 65%. So that is a very good success rate. Patients who can't have the colonoscopy for whatever reason, and they get it through a pill, either be NG2 or EGD, that also has a good success rate in the 80s. And then most people are pretty much resolved with all symptoms within 1 or 2 weeks. Patients who fail usually fail quickly within the first 4 weeks. But then some studies, they've done some randomized control studies, and they show that the patients who fail, if they get a second FMT, out of all the failed patients, they all had 100% recovery after the second FMT. So really, it's something that if you're having a patient that's having some real difficulties with recurrent C. diff infections, this can be a real game changer. Probiotics. So this is something that we all kind of do, although the guideline recommendations really don't support or refute this. Really doesn't show any good data showing that probiotics will prevent CDI or prevent recurrence. It's almost like the PPI things. Most of the data trends toward it helping, but it's not statistically significant. So, unless there's a problem with the flora story you're giving or whatever, it's not really contraindicated at all, but it's not actually recommended officially through the guidelines either. And then anti-motility agents. So there are no official recommendations whether to give it or not to give anti-motility agents like glopamide for C. diff infections, mainly because the studies that have come out show that the anti-motility agents aren't necessarily a problem if given with appropriate antibiotic treatment. So this is like one example I found. So this was a literature review. This was going over about 20 different reports, kind of pulled all these different case reports together. You can kind of see the numbers there on the screen. But really, just to sum it up, the patients who got anti-motility medication before antibiotic treatment were the patients who did poorly. So the patients who ended up dying or had toxic megacolon or at least colonic dilation, those are the patients who got the anti-motility agent without the antibiotics. The patients who got the antibiotics with or before the anti-motility agent all did well. So if you really feel like you need to give one of those things, just make sure you've been treating the patient adequately before administering. I had mentioned some of the medications we've used, so I'll just like quickly go through those. So Zimplava, I mentioned, indicated for reduction of recurrence for CDI or high-risk recurrence for CDI. This is a monoclonal antibody. It's actually directed against the toxin B. So out of the two toxins, A and B, this binds to B. So if you're at a hospital who tells you which toxin they actually isolate, then this can be very helpful for that. It's a one-time infusion, takes about an hour. The only thing you really got to watch out for is it can exacerbate heart failure. So watch out for those days or for those patients. Fidaxomicin deficit. So this is actually a macrolide. This is a really common medication. We don't maybe give it as much as you would think because of cost. It's kind of an expensive medication, but it works very well. You can use it as initial treatment or for recurrent treatments. This is BID medication taken for 10 days. Really only contraindication is macrolide allergy. And then Xifaxan. So this is something that you can do for recurrent CDI. You would add this to the back end of a vancomycin treatment, and then you would add Xifaxan for 20 days, and it's a TID medication. So, I mean, TID medication for 20 days is a little burdensome for a patient, has an increased cost, and then it does have a associated with some resistance to C. diff. So if it's been done before and a patient has recurrence again, I would not go back to this medication. All right, so we'll finish up with the end of this case presentation. We'll kind of go into decision-making and diagnosis. So we'll call our patient non-severe C. diff, first reoccurrence, previously treated with PO vancomycin. And we're calling it non-severe because white blood cell count was less than 15,000, creatinine was less than 1.5, no evidence of toxic megacolon, vital signs were all stable. Clinically, he was presented very benignly. And then treatment plan, so things we need to think about are previous treatment, what's going on with him now, what comorbidities he have, and then how applicable will our treatment plan be for him going forward. So initial treatment was with PO vancomycin. You can make an argument that you would want to switch to fidaxomicin if you failed vanc, although the guidelines say you can do both. This guy who was having trouble swallowing, it's not even clear he was getting his PO vanc appropriately. So it's hard to say that he, didn't fail he failed the treatment therapy or was recurrence, or did he just not get the appropriate treatment to begin with? So we elected to go for oral vancomycin. Concurrent medical issues. So, he had the UTI. So he's going to have, we chose a 7-day course of antibiotics for him, the shortest possible course we could give with what we thought could resolve the infection. So we're going to have to treat him with the oral vancomycin for those 7 days and then start our C. diff treatment. So those first 7 days won't count toward the 10 to 14 days of oral vancomycin that we're going to elect for prior to a taper. And then comorbidities. So we had actually thought about doing some Zimplava on him, but he has a history of heart failure, so he was not a candidate for this. And then fecal transplant also really wasn't an option because of provider availability here in Tulsa. All right, so again, the assessment, non-severe C. diff, first recurrence, previously on oral vancomycin. So our plan was going to stop the IV flagyl, continue with the oral vancomycin. We're going to do the oral vancomycin through the first 7 days for the UTI treatment, and then for a 14-day course with a subsequent taper. You can kind of see what our taper looks like here. You should think about vancomycin tapers like you think about steroid tapers. It's not really a hard algorithm or set that you need to follow. It's really based off the patient and the clinical presentation. The example they give in the guidelines is actually like a week of QID dosing, and then a week of BID dosing, and then a week of Q-day dosing, and then 3 to 8 weeks of vancomycin oral once every 3 days. So, you know, that's a very different taper than what we're doing here. Part of the reason we chose this taper is it's a week of the same medication, and then it changes every week. For compliance reasons, it might be a little easier to follow, especially if there are rotating nurses or if the patient goes home and has to give it to himself. It's not quite as confusing. And then duration, you know, you can do an abrupt stop like we had done with where you do vancomycin 125 every other day for 7 days, or you could taper that out for every other day for 14 days, 21 days, however you kind of want to do it. It really just depends on how long you think you need the taper to last. And then to finish up, follow-up testing. So if you've tested a patient, do you need a test for resolution of the C. diff? And you don't. Actually, it's recommended that you don't retest C. diff after treatment. This is a clinical resolution. So as long as the patient is no longer having diarrhea, they're considered treated. Like we mentioned several times before, patients who had C. diff can be positive on their stool test for up to 14 days, or 30 days after treatment, or be asymptomatic carriers. So do not test people who completed treatment and are asymptomatic. All right, those are my references. Thanks for listening.